What time is it supposed to finish? 12?
Yeah. Actually, you have until 12:45, but it's up to you. You know, it's up to you, the pace, and the break and so forth. But go by the material.
I'll try to do that, yeah.
Yeah.
Okay.
If you need to leave early, don't worry about it. Just cover what you were planning to cover.
We're having a living rosary this afternoon.
Yes.
I'm supposed to be running, and I haven't done one thing other than get one other group involved.
Yeah.
I thought, oh my God, what if the people don't know the rosary?
Yeah. Oh, they'll pick it up.
That's what I'm thinking, you know.
Okay, I sent this link out already, so I'm going to begin kind of formal the introduction.
Okay.
Morning, everyone. Welcome
Good
back.
morning.
Okay. This is the Healthcare Bioethics course in the program of Bioethics at St. Thomas University, Master of Science in Bioethics. And today we have Dr. Mary Jo O'Sullivan, and she will do her own detailed introduction, but I just wanted to do that brief introduction. Very fond of Dr. O'Sullivan. Been practicing OBGYN in Miami for many, many years, and throughout the world, actually. I'm sure she'll tell you more about that, but also I'm very proud that she was one of the students in the first cohort, the inaugural cohort of this program a couple of years ago. So, Dr. O'Sullivan, welcome.
Thank you, Father. Good morning, everybody. It's a pleasure to be here. The last time I gave this lecture was to my own class last year. It was really an interesting experience because it was somewhat different from what I'm used to doing. Usually when I give lectures, they're all scientifically oriented, and this isn't quite that scientifically oriented. A little about myself, as Father said, I practice medicine, obstetrics and gynecology at the University of Miami. I came here in 1977 and retired in 2007. Part of what I did was research as well as teaching and the actual practice of medicine, teaching residents, medical students, nurses, etc. I was very much involved in the HIV epidemic and worked with a team that actually developed the information using AZT of being able to prevent, or significantly rather reduce, the rate of perinatal transmission of the virus from the mother to the baby by the use of a single drug. Today, now 3 drugs are used, and so perinatal transmission is extremely rare. When I retired, a little bit about what I did after that, I was in Afghanistan for 3 months teaching OBGYN, mostly OB, at the Rabia Children's Hospital, at the Rabia OB Hospital in Kabul. And then after that, I started working with a group called Medicine in Action, doing missions in Jamaica and Tanzania. From there, I still work with them twice a year. I no longer operate with them, but I do the clinical women's healthcare work. In addition to that, I'm trying to think what came next. I started working with North American Lourdes volunteers, taking sick from the States to Lourdes, sometimes some very, very sick people. Quite a challenge for an OBGYN as the lead physician. And more recently, in fact, this past week, came back from a trip with the intent to take sick from China to Lourdes. Unfortunately, although our first trip was extremely successful, the last trip was a dead dud because the Chinese government did not give any of the sick exit visas out of the country. So we had to go all the way to China to find this out, and then make the trip to Lourdes and go back to China because the tickets were paid for. Anyway, so that's basically what I do now, plus a lot of work in my parish, leading the Respect Life group, the Catholic Council of Women, and the Over 50s Club. So enough about myself. Let's talk about the patient-physician relationship, which actually has undergone a great deal of change over the centuries. So what I'm going to do is to start off with an historical background and gradually work up to where we are at this point in time. So let's go back about 6,000, 6,500 BC, when it seems that this was the first indication that burr holes, trephination or burr holes of the skull were detected using skeletons that were determined to be that age. As a matter of fact, more recently, there were some bones discovered in a field in France in which 1/3 of 120 skeletons had evidence of burr holes. And some of these people, of course, survived and some did not. The idea behind all of this was to remove the skull bone to relieve pressure from the brain. And the pressure might be because of a blood clot in the head. How do you know that? At that time, well, from trauma. It was also used to relieve the signs and symptoms of epilepsy, severe migraine headaches. Sometimes it was magical, sometimes it was curative. But one of the things, and we'll show you again, it was extensive throughout the entire world. All ages and all sexes had evidence of trephination. In the 18th century, we'll move on a little bit, probably come back to that again, but in the 18th century was the first set of laws regarding medical practice, the Code of Hammurabi. It was extremely detailed in the sense that there was a system whereby Hammurabi described how much would be paid for any procedure a physician did, provided the patient was cured. If the patient was not cured, then the physician was not paid. The payment was on a sliding scale based upon the status of the individual patient, from the higher up, very wealthy, to the slave, for which the payments were much less. Unfortunately, if there was medical malpractice or the patient died, the physician had to pay a price, and that price could be a hand, fingers, 2 hands, or his life. Going on to ancient Egypt, there were many surgical treatments of wounds that have been discovered from texts and papyri that are available today, describing many of these types of procedures in medical care. If we look at the Old Testament, you know, it's very, very interesting in the book of Leviticus, how many laws were laid down by God to Moses for the Israelites. And when you read that whole section, which starts, I believe, at 11, Leviticus 11 and goes to 20, it is very detailed about each law that he is giving the Israelites. And if you try to look at it from the medical perspective, then it becomes clear that he's thinking of prevention of disease. For example, they were not allowed to eat pigs. Pigs were a source of trichinosis, which is a parasitic infection, which is still in pigs today, but far less than it was back in that time, or even as far back as 50 years ago. Another one would be blood, being exposed to any kind of blood from any animal. That was a taboo. You were unclean, and blood is the source of infectious diseases such as hepatitis, for example, or HIV. There were rules regarding handling dead bodies. One could take that information today and think back about the Ebola epidemic. And one of the reasons Ebola spread so rapidly in Africa is the handling of the dead bodies, which were the source of infection to those who could handle those bodies. So, I mean, there seemed to be a lot of preventive medicine that God was giving to Moses during that period of time. You should go back really and take a look at Leviticus. It's kind of interesting and a challenge when you read it, and then try to think of what this might mean in today's world. To go on a little bit further, Aristotle, he was of the ilk that the heart was the seat of the spirit and the source of life. And do we know that to be the case today? Of course. The heart is the center core of life. If that heart stops beating, life is over. And yes, maybe you can bring life back, but you have to do it in a very short period of time in order to maintain brain function. Now, beginning around 100 AD, there was more the beginning development of medical theory, and leeching began to be used. Although it had been used before, it was nowhere near as extensive as it began to be, starting about the year 100. Throughout the world, and this is just not limited to the Babylonian era, but throughout the world, whether you were in India, China, the Arab countries, all had their own ways of practicing medicine, which they developed through time. The Arabs actually probably had among the best medical and surgical procedures during their era of popularity, but a lot of that was lost. And it's really sad when you think that today that area of the world is so impoverished and so poor and so distraught by war, when there was a period of time that they actually were so far advanced in medicine and the sciences than actually we are perhaps today. Then you go to going on a little bit more and you move to the more recent times, and they're not so recent really, but 1100 to 1930, first of all, medicine was kind of slow in development. It didn't seem to be going anywhere once the Arab world shut down. It was more magic. It was more using leeching for treatment. The poor were the only ones that were in hospitals. There was no such thing as a healthy person, as a rich going to a hospital. The hospitals were first started in Italy, and they were started for the poor, the mentally ill, and handicapped persons. And the care providers were predominantly the Catholic women. But the concept of a hospital as you know it today was not what it was back then. The first medical school was in Salerno, Italy. I mentioned the business about the Arab and Jewish history regarding the sciences that were available to both groups at that time. I talked about already the Catholic women caring for the poor. Nursing schools started because of Florence Nightingale. European dispensaries where people could come to get medical care began to be developed in the 15th century in Europe. And then as we move on to more recent times, in the 1800s, the first US medical schools got started. And in 1900s is when we can begin to see the development of modern medicine, antiseptics, anesthesia, and development of medications. So from the patient-physician perspective, the doctor from ancient times, the so-called doctor, and not all of them had any real education to be that. Some of them were just on their own, they decided to be doctors. Doctors were also barbers, really, surgeons. They might have an apprenticeship with somebody who practiced medicine and then went off on their own after that. But there was very, very little real education regarding patient care, how to treat patients, and so on. But the patient themselves always looked to the doctor for a solution to the problem. And what the doctor said, the patient did. So it was very paternalistic. The patient never challenged the doctor. The doctor said the patient did. The doctor said the patient did. The doctor said the patient did. Never, no questions asked, and so on. So that was the case really up until the Second World War. And actually a great deal of development of medicine has been since then. Before that, there was really very little of anything. And as I mentioned, anesthesia had just gotten started. It allowed for operations to be performed, but the big problem with the operations was infection. So there was a very high death rate because there were no antibiotics to treat these infections. And those antibiotics came into play during and right after the Second World War. I can remember myself being one of the first people after the Second World War taking a sulfa drug and mixing it, the powder, with molasses to take care of an ear infection. So I clearly remember that. My father was among the first two, as were soldiers, to get antibiotics following an accidental amputation. So it's hard to really realize this, that penicillin wasn't really used extensively until the Second World War. Okay, and penicillin was an accidental discovery. It was just found, this yeast was seen on a piece of bread in a laboratory, and it was noted that, oh, by the way, the organisms near where they had this were dying off, and then they tested it and to see if it did kill off organisms. In fact, it did, and then they investigated this particular substance, gave it a name called penicillin, and there we go. I can remember being taught as a resident, you must be very, very careful with the use of antibiotics. Now, I'm talking about, sorry, as a medical student. I was a medical student from 1959, when I first went to medical school. And antibiotics were expensive. They were rarely used. But we were taught that if you're going to use them, you must use them with care. You must be very careful in terms of the right drug for the right patient, for the right organism. Because if you're not, what's going to happen over time is the bacteria will become resistant to the drugs that you use. And I can attest to that fact because when I did my residency back in 1963, we used to use penicillin, streptomycin, and chloromycetin to treat women who had septic abortions. And we could treat them with 1 million units of penicillin, 500 milligrams of streptomycin, and 500 milligrams of chloromycetin, IV. And we would give that every 6 hours until the infection was eradicated. At the end of my residency, we were using 10 million units of penicillin for the same patient, 2 grams of streptomycin, and 2 grams of chloromycin. So it shows you that in 4 years, there was this major progression towards resistance to the antibiotics. Well, getting back now to the slide, autonomy began, that idea that the doctor was right and you did everything that the doctor said began to change with the information that came out of the Second World War with the Nazi experiments. None of the candidates for experiments in Nazi Germany gave consent to anything. It was all forced. And horrible things were done to these people. We can't ourselves in this country not take blame for something similar. What was the something similar? The Tuskegee experiment on syphilis in Black men, in which the men were never told that A, they were in a study, they never consented, B, half of them got antibiotics and half of them did not. And they were never told why, what for, or what the purpose was. And it wasn't until the 70s that this whole experiment became known. And this resulted in the idea that any kind of study that was to be done had to be done with consent, informed consent, and the patient had to be fully explained every detail about the study. And there were now regulations, as there are continuing to be, regulations out of the NIH, out of the US government, out of ethical committees about what free and informed consent really is all about. And that's because, again, that paternalistic attitude that the doctor knew best and whatever the doctor said was what was going to happen. So, as I've already alluded to, there were marked advances in medicine, surgery, and diagnostic techniques after the Second World War. And these have continued with every war we've had, by the way. Things progress much more actively during wartime because we want to keep our men going, we want to keep them healthy, we want to give them the best medical care we can, or we should. So there's also much more research being done during war times. And this has now extended out, of course, into peacetime. There was the development of specialty care before the war, the Second World War. You know, you were in a doctor, and doctors did everything. Even general practitioners operated appendectomies, sometimes major surgery, with very, very little training prior to doing these procedures. And the development of the surgical specialties all came about again after the Second World War with this development of trauma and then Korea and so on. And medical specialization became so vast that even though from the beginning of your medical school, you're being taught you need to be a primary care doc. We need primary care doctors in the United States. And what's happening is, oh yeah, a lot start out that way, but then they find out that's not where the money is. There's very little money in primary care. You only have the patient for you have the patient for a long period of time, I'm sorry, but you don't really make sometimes even enough to survive if you're out in the rural areas. So many students go on into specialization, and so we end up with compartmentalized medicine. You go here for your ear, but if you're an ear doctor, you only do outer ear, and the other ear doctor does middle ear, and the other ear doctor does inner ear. So it gets to be so specialized that they cone down so much on one area that they begin to lose their knowledge of other areas. And so you, the patient, goes from doctor to doctor to doctor forever, it seems. And it's very sad. It really is very sad. When it came to modern hospitals, remember that I told you that the initial hospitals that were developed were really places for the poor. In this country, for example, there were very few hospitals in the 1800s. In the 1900s, we went from approximately 700 hospitals in the 1800s to somewhere around 18,000 hospitals in the 1900s or more, and continually increasing and now decreasing, because we're going from inpatient care all the time to more outpatient care. Why is that? That's because with the development of healthcare insurance, patients no longer took into account what the cost of anything was. The insurance will pay for it. So they wanted, and still do, want everything possible that they can have. The problem is, in order to contain costs, one has to be able to say, okay, no longer will we admit patients to the hospital where things can be covered, but rather all of this has to be done as outpatients. So all of medicine has just continually undergoes these changes in how patients are cared for. This includes the communication issues between patients and the physicians. And also, as I point out here, the tremendous need to educate the patient, the family, and the local populations as well. So medical education, or teaching patients as well as the physicians, is extremely important, and it's central to the practice of delivery of high quality health care. Now, true, obviously, you want to have confidence in your physician, right? Yeah, say yes. Okay, I just want to make sure you're alive. Okay, so you want to have confidence in your physician so that when you're having your diagnosis, you know, you're talking to your doctor, the doctor and you are communicating back and forth. It's not anymore, okay, you're going to go for this test. It's, you're going to go for this test, and this is the reason why we need this test. And this is what the outcome, what we expect the outcome to be. And the patient can then question everything. Communication has to be in both directions. It cannot be, I tell you what you're going to do, you just go do it, you don't ask any questions. Now it's back and forth. And when you talk to patients in today's world, not only do you present, you start off with, what do you think you want? What do you think you have? What do you think you want? How do you feel about this, that, or the other thing? Then discuss what your own opinion is, and then how we're going to work you up. And then, are you willing to go along with it? Do you want to do this? I mean, it's all a matter of give and take. And the patient can refuse, and that's perfectly fine. But you're not required to do anything that's within you're not required to do something to which you morally object. Okay, and even though at one time, it looked like the federal government was going to try to impose that upon us, so far, so good, it hasn't happened. But there was a period of time when people like myself were worried about the fact that if a woman wanted an abortion and she came, we had to do it. We were not allowed to send her to anybody else. And that's what the government wanted. But fortunately, it didn't happen. Thank God. Then the other thing, some of the other things that happened in the whole field of medicine was the HIPAA laws, which we'll come to in a moment. Then patient-centered care. Everything had to be directed. The patient is the center of everything, and everything has to rotate around the patient. Okay? You know what I mean when I say that? Okay. And that leads to your shared decision-making. So the 8 principles of patient-centered care are listed here. And I'm sure you can easily read them, but it's obvious that we need to respect the patient's values. Nobody ever asked that question. You know, I remember being taught that, but I can remember being with doctors who didn't even have any concept of asking about to the patient what the patient value was. For example, I can remember being in the operating room assisting at a cesarean section, and the attending physician, that before I knew what was happening, she grabbed both tubes and put clamps on them. And I'm like, what are you doing? You know, as a resident to say that was like, you don't do that in that time. What are you doing? She said, keep quiet. I said, what? Keep quiet. She's had enough children. And really what she was doing was, by clamping on the tubes, she was essentially sterilizing the patient or preventing her from having pregnancies in the future. And no consent, no discussion. And she had never told the patient postoperatively. And I know that for a fact because I took care of the patient. The patient had no idea. Never told the patient.
Even after?
No. No. Right. And that was done. I can tell you that one of the things that a charity hospital in New Orleans, which was predominantly Catholic hospital, and patients were predominantly Catholic patients and had large families.
Where was this thing?
In Charity Hospital in New Orleans. And this would be in the 30s and 40s. It may be in the 50s as well. Yeah. Yeah, and in the 60s, yes. If a woman had to have a cesarean section, and for, let's say she had 5 or 6 or 7 kids, and she was having a cesarean section, they would go ahead and get her consent for a cesarean hysterectomy. And that meant that she would not have any more children. And that was not necessarily because she really needed the procedure. It was more a way of sterilizing her. If a woman had descent of her pelvic organs and she was still of the reproductive age, they would have this discussion whether that if they tried to do anything with this, it wasn't going to be successful, so the uterus would have to be removed. And I was like, why? And even when I went to UM, they were doing this routinely on women who had pelvic floor, what we call pelvic floor relaxation, which means that the uterus was descending out or that they had problems with urinary incontinence. They were all signed up for vaginal hysterectomy and repair. I said, why did you take the uterus out? That would be my first, when I first went there. Why are you taking this uterus out? What do you mean? We always do that. I said, well, she doesn't need it. There's no reason for her to have that hysterectomy other than she's got descent. We can re-support that. Why don't we give her the option? So they've changed the procedures. The patient then got the options. I was called, what was I called by one of the residents?
Probably needed to talk to you.
No, one of the residents said to me, oh God, I can't forget how it went. But anyway, it was an expression I'd never heard. She said, I have to say you have balls. I'm like, what is that? I had no idea what she was talking about. Talk about stupid, innocent. I had no idea that I fought the chairman so that these women could keep their uteri.
And what is the procedure that they do to keep the uterus?
You just resuspend it.
Okay.
You know, some of them didn't have descent at all. You know, the majority, I mean, really the majority didn't have descent. They just had a cystocele, which is it's not really a hernia, but everybody calls it a hernia of the bladder. Or a rectocele, which is not really a hernia either, but it's the rectum coming out through the vagina. Okay, and the repair can be done locally without doing necessarily a hysterectomy, especially if the uterus is in its appropriate place. Okay, so I mean, these were things that the paternalism of medicine dictated, and the patients didn't know any better.
Yeah. Or they didn't want to challenge the doctor, right?
Well, you know, in Europe, that's still the case. You'll see that. I mean, I spent a lot of time in Ireland, and I get involved a lot with family and relatives in medical care. And I'll say, well, what did you ask the doctor this? Well, no. Well, did you ask that? No. But did you want to know? Yeah. Well, why didn't you ask? Well, you don't want to bother the doctor. What? Of course you want to bother the doctor. That's your body, not the doctor's. Yes.
Sometimes I don't think the patient knows the question that they need to ask.
Well, this is true. Sometimes they don't know. And we'll come to a little bit about that and how internet can help with that too, and education.
Yeah.
Okay. And then we get the opposite side. We'll come to that because now you get the opposite effect. Okay. So amongst the other things was too, the recognition of the patient's religious beliefs. This was not something that was very common at all. actually, the first time I ever saw that was when I left my residency and went to New York. And when I went to New York, it was the first time I was in a hospital where they had chaplains. And actually the chaplain was called for every single patient going to the OR, was asked, do you want to see the priest or the rabbi or the pastor? And it was amazing how many people did. Absolutely amazing. So that was my first exposure to that. Now it's pretty consistent. Almost every hospital has some type of chaplaincy service. And some of them have multiples. And some of those chaplains are full-time. For example, in our hospitals here, every single hospital of major note has a Catholic chaplain. Every single one. And it's great because that's all they do. They're not responsible for a parish anymore. As in the old days, it used to be that the local parish priest had to come to the hospital to give the last rites and so on. Now, no, that's all done by the chaplain. And of course, the way last rites are given today are quite different, and the rules are not quite different, but somewhat different. So it makes it easier for them. So it was the recognition, again, of religious beliefs that we have to respect and follow. One of these classic examples that I can talk about is a Jehovah's Witness. I mean, if you have a Jehovah's Witness and OB, a pregnant Jehovah's Witness, one of the biggest problems we have to deal with in obstetrics is postpartum hemorrhage. And while it's increasing in frequency, unfortunately, it can be extremely traumatic and can happen so rapidly, and the blood loss can be so fast. So every single patient, pretty much, I think, at least at Jackson anyway, always signed consent when she came in for delivery for cesarean section, hysterectomy, blood transfusion, so that we covered the gamut. And we're not trying to do all of those things, doing procedures as an emergency without some knowledge that the patient would be aware that this was a possibility. And it was hard, hard to get it started because, it's frightening. You come in to have a baby and then you're asked, okay, here you have to sign for consent for vaginal delivery, for cesarean section, for cesarean hysterectomy, always every delivery, blood transfusions, of course, blah, blah, blah. Well, Jehovah's Witnesses, no blood. So what do you do? Well, I've saw all kinds of things done. I've saw blood given when they put the patient to sleep and give them blood. Well, that's not correct. That's not the right thing to do. Jackson started a policy, a Jehovah's Witness type service where everybody who was a Jehovah's Witness came into the hospital, had a consult with that service. So all the necessary legal forms were properly signed so that if we didn't give blood and the patient died because she didn't get the blood, we were not legally liable. Well, what happened for me, I'll give you a great educational example for me, was I was taking care of an American Indian who had leukemia. And she was pregnant and she was in the hospital with a fever, high fever, due to bilateral ear infections. And her hemoglobin was 4. And the normal hemoglobin is 14. In pregnant women, maybe 11, 12. But hers was 4. So I was talking to her about a blood transfusion because she's got a severe infection. And in the conversation, it came out. She said, if you give me that blood transfusion, and if I consent to that, and or you give it to me without my consent, do you know I'm going to go to hell? And I said, why? And she explained to me, in their teaching, that was condemn them to hell. Never again would I bring up the subject. I would always bring it up, but never again would I push towards a blood transfusion. I needed to learn that lesson, but I didn't know that. Actually, that same woman came in and had her baby, and again, with a hemoglobin of 4. And anesthesia, of course, was uptight. How do I put this patient to sleep with a hemoglobin of 4? And we had discussed it. Of course, she'd all signed all the necessary forms. She indeed did code on the table, but we got her back. She ended up, after the surgery, with a hemoglobin of like 3 point something. But eventually, she left the hospital with her baby and lived another 6 months before she died of her leukemia. But just shows you what you can do, because in India, it's not unusual for women to have hemoglobins of 4, 3, 5 when they're pregnant. And they're so nutritionally imbalanced. So when you see that in the United States, you like freak out. But when you see it in India, it's, I won't say it's okay, but it's common procedure. Okay, now the other things of bioethics committees began to appear in the latter part of the 1900s, when ethics really became more of an issue following the Second World War and how we treat people in the medical arena. So today, it's expected that every hospital will have some type of ethics committee. Now, when I say some type, there are ethics committees and there are ethics committees. Catholic hospitals, the ethics committees are going to be really attuned to our traditional Catholic teaching. In non-religious hospitals, it's the ethics of the day that you're dealing with. And that's not the same. They don't have the same value. For example, a fetal life, they just don't. You would be, and I have been in this position too, where you have to get the ethics committee consult because this woman is dying of a disease and she's pregnant and she needs to be treated. And the question is, what's the best treatment for her under that set of circumstances? And so the ethics committee comes in and they will always say, abort the baby. Well, no, she doesn't want that. And so you'd have to fight against it. I can remember the present Archbishop, one time he was a very young priest. And I had a Haitian patient with AIDS who was terminally ill. No, sorry, breast cancer, who was terminally ill. And she was, 24, 25 weeks pregnant. And she did not want to take anything for the cancer because of the baby. She wanted that baby so badly. And she knew, the way I understood it, she knew that this medicine could damage the baby. Well, actually, it didn't, but Archbishop was great, then Father Wensky was great because I said, I need somebody who can really understand this woman's language because I didn't trust the translators. I need somebody who really trusts her language, who understands her, and who from the religious perspective is gonna give me the right information. And he was fabulous, he really was. I'll never forget him for that, never. So, okay, bioethics committees are the big thing today in the sense of decision-making of controversial issues that doctors have to deal with involving patients. And then those bioethics committees also involve the patient and the family. So it's not just for the physicians, it's for the physicians, the nursing staff, the laboratory staff, the patient, and the patient's families about decision-making. And as I mentioned before, neither the patient nor the physician has to do things that go against their own values. They're not required to do this. It may be an argument, it may be a fight, but you're never to be forced to do something against your own values.
So I have a question.
Sure.
So if you are a physician and you don't want to give birth control, that's okay?
Yeah, I know. I did for a while and then I stopped. When I began to realize what it was really all about and what I was really doing, then I stopped. And so, well, I won't say I stopped. Let me put it this way. What I did was I had the secretaries, I worked in an environment where I did not have contact with the patient until I saw them for the first time. The university schedules your patients. So on my schedule criteria was nobody for birth control. So I never saw a patient for birth control after that. But I had a very large clientele of very sick women, because that's what I did, high risk OB. And for those women, after the baby was born, I would, if they wanted contraception, I would provide the contraception with the idea in mind to get ready for the next pregnancy. When it came to renewing it, I said no. I will give it to you for a period of time until you're ready to have your next baby, but not permanently. And of course that, in a sense, goes along with the, what is the encyclical? Humana Vita, yeah. Where a woman has the right to, a couple has the right to make the decision to delay childbirth for a period of time until whatever the issues are settled, but not permanently.
But the issues are medical issues or?
They have to be the issues that the couple decides is important to them. The church doesn't dictate what those issues are. It could be financial. They can't afford it for now. It could be medical. What else would there be? Medical or financial?
Well, why didn't they just abstain? Or
Oh,
be responsible, you know what I mean?
yeah, that's what you'd like them to do.
Natural family planning.
Well, that's the method of contraception that they're supposed to use.
Yeah.
That's what they're supposed to use. And that's, you know, it takes two truly committed people. And when I would suggest this in the office, the women would all look at you and say, my husband? He's not going to go along with this. There's no way. What he wants, what he wants, when he wants it. Well, she's being used.
Yeah.
And I would tell them that you're being used. But you got to be careful because you can't break up a marriage.
Yeah.
You know, you have to be very, very careful how you do that.
Like kind of say it in a funny way or.
Yeah, I mean, you don't want to put things that are going to make the split.
I was listening to an argument and they were saying that here some women take birth control because it helps other issues.
With the cysts, with
That's not for birth control, though. You're not doing it for birth control. If you're giving or a contraceptive, which by the way doesn't work for cysts, but anyway, if you're giving it for that reason, okay, you're not giving it for contraception. Whether they're sexually active or not is a whole nother issue, okay? Your purpose in giving that medication is to reduce the development of cysts. That's your purpose. If they're using it for contraception, that's not your intent.
Right.
Okay?
I used to have students of mine tell me, and they were young, because I used to tell them about birth control and how bad it was, and I would give them like all the information, and then like after they would see me after class and tell me, oh, I just got on it because of like issues with the cramping is so bad. And
Well,
I said, did you try Advil? How
Yeah,
much
yeah.
Advil did you try? Are they pushing this on you?
Mhm.
Like,
Yeah. There are more, there are better methods of treating than just putting them on birth
of
control
course,
pills.
but
And birth control pills are synthetic drugs,
Mhm.
you know, and they're synthetic testosterones. They're male drugs. And we don't know really the long-term effects of all of this stuff. Unfortunately, with natural family planning, you know, it really is, it has to be taught. You have to have the couple together. And the couple together has to be committed. And together they have to work at it. And even if the woman wants to do it and he doesn't, it's a battle, okay? And, you know, what can I say?
But you know what, like the training of abstinence before marriage, like it helps, you know what I mean? To get
We live in a
discipline,
different world.
you know?
It's so
But
sad
it
because
just helps
one
us.
sexual partner brings one set of STDs, 2 brings 3, 3 brings now geometrically increased risks of STDs. I mean, I can tell you when syphilis and gonorrhea were the only 2 major STDs that you had to deal with,
Mhm.
really? Oh my God, they would call it catastrophes. If a patient had syphilis, it was a catastrophe. If a patient had gonorrhea, it was a
Now they
catastrophe.
don't care.
Oh, big catastrophe. Then herpes came along. Human papillomavirus has been with us forever. But then herpes came along. Oh, no, this was worse than syphilis and gonorrhea. Okay? Then the next thing that came along was HIV. Well, all of these came about for what reason? Increasing promiscuity. The birth control pills, increasing promiscuity, you know.
Everybody's sharing juices.
And so, and when you educate a patient about STDs and they come in with one, how did I get it? I say, well, excuse me, but what did I tell you? What did I tell you? How did I get it? Oh, but he says he's never, don't tell me he's never. They never tell you the truth.
Of course.
And you never tell them the truth, so don't give me that.
Yeah.
Oh yeah. Oh yeah. Oh yeah. I mean, our world today,
Yeah.
I want what I want when I want it, how I get it, doesn't matter. And that's a problem with our lack of,
It's become a sport.
Hmm?
Like sex has become a sport. You know?
I can't understand it. I personally cannot understand it.
People are savages.
I can remember my own,
Because of like the ads we have, like the sexual revolution.
Everything is sex.
Everything.
Since birth control pills.
Yeah.
And I can remember when they came out. But since then, everything is sex. The teeth, everything about you is sex. It doesn't matter what you look at. It's all sex. Look at the little kids today. 10-year-old women, mothers are dressing their 10-year-olds like they're 20. I'm like, how could you put heels on this 10-year-old? Strapless dresses. Oh, yeah.
And I'm like, how does a dad, like my dad would never let me leave the house with little
But
shorts like
they're
that.
immune to it today.
At mass.
But that's someone like me.
Oh, yeah.
My daughters, you are not going on.
He goes, take off that skirt now.
Stay
Oh,
home.
yeah. My father was the same way. Even with my mother. No, Annie. He'd say, well, Annie, no. You got to put a sweater on. You're not going out in that sleeveless thing. And to us, no. Change.
It's really women, women are the problem because if women set the, respect themselves and say, no, I'm not going to dress like this. No, I'm not going to get into that.
It is us.
Men just follow.
Oh, yeah. Well, look at Adam and Eve. That's always been my classic example. Who ate the fruit first?
Yeah.
She did. And who tempted him? She did.
Oh.
It's true.
She's the weakling.
I know.
Oh,
Okay.
he's the weak. I don't know. I guess they're both.
Everybody's weak.
Yeah.
We're all weak in a different way.
But I do believe the wife plays a bigger part in marriage.
The wife, yeah.
Yes.
Well, she's got the kids to keep in mind.
It's plenty, because if she decides it's not going to work,
He's
it's not
gone.
going to work.
If he decides it's not going to work, what?
No, if she decides that it's not going to work,
It's probably not going to work.
it's not going to work.
Well, I feel so sad.
Nobody pays attention to the guy. So,
I feel so sad when you see these women with handicapped children, and he's gone. He's gone. He does not stay. Once he sees himself in this environment, and she's paying a lot, because she has to pay a lot of attention to the child, and he's feeling neglected. He goes.
off the record, man, I didn't need that. That's off the record.
Okay, so the new religious directives from the USCCB are the 6th edition. I think you probably have, okay? And I think it's just pointing out that our responsibility in our physician-patient relationship is to have respect for the patient. The patient's responsibility is to try to trust us as much as she can. Both have to be honest with each other, and believe me, that is very difficult. Patients are not honest. It takes maybe in my specialty, it may take 4 or 5 visits before you finally find out what the real reason is that she's coming. It's not always in the beginning. Of course, we have to be as confidential as we possibly can regarding care, et cetera, except when it comes to domestic abuse and sexual abuse. And of course, we have to avoid manipulating patients or intimidating them or being condescending. And as it says, neither of the two are independent of each other. So what are some of the barriers of communication between the physician and the patient? Patients will waste your time. They'll come in and, like I said before, the real reason doesn't come out in the beginning. Oftentimes, it's as you walk out the door, you have your hand on the handle, and the patient says, can I ask one more question? Now you know, this is the real reason.
That's funny.
This, after an hour, this is the real reason. But they have to learn to develop confidence in you. And they don't know how you're going to judge what they say. So they're afraid that if they say something, you will judge them, or you will criticize them, or you look down on them, okay? And they see, too, the difference between you and your educational background and themselves, especially if they're poor, or they're of a different color, or they look different, okay? Because they're uncomfortable. It's not a comfortable environment. And this is becoming even more so as you see all this racial divide, okay? Not that it wasn't there before, it was, but it was not as, except in certain parts of the country, it was not as obvious as it is today. And I think that that's an extremely difficult thing for both the patient and the physician. Okay, so if you come from different cultures, if you look different, if you speak differently, if you have different educational backgrounds, it makes it very hard for a patient to communicate in the way the patient feels comfortable. And that's where you have to make the patient feel comfortable. So how do you do that? Well, one of the things is that you make sure that you're both sitting and the doctor is not sitting above the patient. For example, you should both be at the same level, okay? Sometimes if you, for example, if the patient's sitting on the chair and you're sitting at the table, at the examining table, you're above the patient. So the patient feels you're talking down. Better to have the patient on the exam table and you sitting on the chair so the patient can feel like there's not space. There's not this me-you space difference. It's always looking at the patient, talking to the patient. How do you do that in today's environment of electronic medical records? It's almost impossible because the patient's sitting here, the computer is here, and you're talking to the patient and you're typing on the computer, and you can't watch the body language. And to me, that was the most important part of my conversation with the patient, was her body language. Because there are expressions, you know, a look can tell you, uh-oh, there's something here, you know, male or female. You just get the right look or the right expression. And that's very difficult and with this whole new system. And it was not easy before. So it's even less easy now with electronic medical records. So that's one thing. The second thing is, if the patient's language is not the same as yours, then you ask the patient if she wants some member of her family or somebody from the office to help translate, okay? Because you want to be able to speak in a way that you know what she's saying and she understands or he understands what you're saying. And translators, you have to be very careful too, whether they're family or not. Used to be years ago, we always used children as translators, okay? Well, you know, when a 30-year-old mom or a 40-year-old or 50-year-old mom is trying to communicate with the doctor some rather delicate issue, and her translator is her 10-year-old son, obviously there's going to be something lost in the whole translation. It's not going to come across the way it should. And so you're working in the blind. And what you really need is leave the children out of it and have somebody else who the patient selects ideally as a translator. Because even a family member, a husband as a translator is not a good idea, especially when it comes to the field of gynecology. It's not a good idea. You need somebody else. If he's the only one, okay, he's the only one, but you gotta watch them because the intercommunication between the two of them tells you a lot too, in terms of what he's actually telling you and what she's actually telling him. So it's really detective work. It really is. Okay, so we talked about all of these little issues. How do you overcome the barriers? We started to talk about that. Let the patient know that, you know, sometimes there are things you don't want to talk about, and maybe you don't want to talk about them today. So if you want, you know, another time to discuss this issue, we can always set you up for another visit. Leave the door open. Here's the phone number, give me a call back. In a domestic abuse situation, for example, when you're trying to get them to get help, and women who are in domestic abuse relationships are notorious for not getting help. No matter how many doors you open, they always feel it's their fault. If it wasn't what they said, it was what they did. It's how they act, to get them to understand, no, that it's not that. And then to get them to understand that when it's not you, it's going to be the children. And then she's really got to protect the children. And some of them, the children are already abused by him. So it's really trying to work very closely with her, giving her information, leaving information in the ladies' room, for example, on domestic violence and abuse, that she can just pick it up and take it and go without telling you anything. You leave these pamphlets around so that women can have the opportunity to at least look at them and not feel that somebody is pushing them to do something. And they can come back to you or to the domestic hotline or whatever the case may be. Okay, what time is it now?
No.
9:20? Okay. And always ask the patient, one of the most important things to do is at the end of every visit is always ask, have I answered your questions? Is there anything else that you want to talk about if you have time? I don't know how many of you have been to a doctor recently, but every doctor's on a time schedule today. Okay, so they have so many minutes to see a patient. And so they can't answer all the questions. So what they have to start off with is, of all the problems you have, of all the questions you have, what is your number one question? Some of them don't know how to deal with that. So you got to try and go through, and then you decide, okay, of all the things you're telling me, why don't we start here? Is that okay with you? And then the next time we'll work the next one. But you have to keep a record of all of that, because you only have a short period of time to talk about it. And you can't cover everything. Of 15 questions a patient has, you can't cover all 15 and still examine the patient and tell them what to do, or give them information about what to do, share what should be done, and get them out in 15 minutes. It's very hard. Almost impossible. Okay, but always still open the door for questions. Let them know that you're there. Anytime they need help, if they can, and then getting an appointment. So it's really, in many ways, very hard for patients still in today's world. Yeah, I think that this is important, to look at everything, try to look through the patient's eyes, but that's where we have cultural differences. It's hard to do that. Okay, I mean, I can see that from my own background, then having worked in Jamaica, which was a great experience, then having worked in an African-American culture for a great part of my life, then switch to a Spanish culture down here, okay, and then go abroad to the Muslim world, and you see everything is so different. It's so different. The methods of communication are so different. The reticence are so different. The ways of saying things are so, how you say something can be very different and can be damaging. So it's really important to know the culture of the people that you're working with. Now, one of the things that we are starting to get into is that when you recommend testing, for example, in my own specialty, one of the things that we're required by law is to give the patient information about prenatal testing. And if you as a physician know that the patient will abort that baby pending the results of the prenatal test, then you are aiding and abetting that decision. Unless you can somehow work with her to get her to understand that just because she has a Down syndrome doesn't mean that that baby needs to be aborted. 90% of all Down syndromes are aborted. 90%. And there's no need for it. In today's world, no need. Because they can go to school, except, almost all of them. I said 90% can go to school, and maybe 98%. Many of them can go out into the working world, and you go to Publix and you'll see, you'll see them. I have not my niece, but my sister-in-law's niece. She's a piece of work. She's Down syndrome, but let me tell you something. Nothing goes beyond her. She's so sharp.
I missed the first part here. When you said that about aiding and abetting. I missed what you said before.
When you have a patient who's coming in for prenatal testing, let's say, and we have to advise her. But if you know that that she's going to abort the baby based on that test, okay, then you are aiding and abetting her decision.
So but you don't know what attorney to do, because you have to be honest with her.
Oh yeah, you have to be honest with her, okay? You have to tell her everything that you can tell her, give her all the information that she needs, okay? But you also have to know that aborting is wrong.
Okay. Yeah.
You're killing. So if you are in any way facilitate that, you are doing the same thing. Basically, you're aiding and abetting her decision, okay? And that's the person that really should be referred to somebody else. Now, some people will say, no, you don't refer them. I can't in conscience do that. I mean, I can't. If a patient wants an abortion, I may not give her the name of the abortionist, but I'll say, you know what, pick up the telephone book and go to letter A. You'll find people. Is that a good thing? No, not really, because I don't know what kind of work they do and so on. But I would rather that she went to somebody that is going to be safe. But
I have a question. So the OBGYN can do the abortion?
no, I mean, can we?
Like you guys know how to?
Oh yeah, we all know how to do an abortion. Because abortion is when a woman miscarries and she has a baby in the first trimester, the first 12 weeks of pregnancy, and she has a dead baby inside of her. Okay, there are various ways of treating that. Okay, we can treat all of them. It's not that much different doing the abortion of a live one. The technical procedures are the same.
I've seen it online when I became pro-life, you know what I mean? I made myself watch the silent abortion.
Mhm.
He was a former abortionist and he explains it, but
Mhm.
I didn't know
Well, see, if there's a retained fetus or embryo in the uterus, and you have choices about how you treat it. You can treat it medically, okay, which is using the same thing they do now to abort, using misoprostol and RU-486. You can do the same thing, okay? Only we would just use,
that's the chemical.
Yeah. we would not use the RU-486 because the baby's already dead. So we don't have to cut off the progesterone, which RU-486 does. We would just give them the misoprostol. And the misoprostol will act by causing uterine contractions and which dilate the cervix and help evacuate the uterus, okay? Or there are some women who don't want that choice. They want you to just do the surgical procedure. So you just do that. You dilate the cervix under local anesthesia and evacuate the uterus.
In the office.
Some people do it in the office if it's very early. And some people do it, a lot of people do it in the office all the time. All the time. But most, in today's world, yeah, you have to be in the office. Or in a surgical, outpatient surgical procedure unit.
So that's really with miscarriages, right?
Yeah. Mm-hmm. And you can do it by suction or by curettage. Okay. We'd like not to do a curettage. We scrape the uterus. It's an instrument they use to scrape out the products of what we call the products of conception, the placenta and the baby. And it has with it a low risk, but a risk nonetheless of complications. Whereas the medical abortion, the chemical abortion rather system using misoprostol doesn't.
And then they would go home and get rid of it after they take that?
They would go home, after they take it. The procedure goes like this. If she comes in and you give her options and she decides to go with the misoprostol, you give her the prescription for the medication and medication for pain. You have to explain in detail what's going to happen, okay? Because sometimes they bleed very heavily. They have to be aware that they will pass the baby at home, depending upon the size, they may or may not recognize it, okay? If they pass the baby at home, then the question is, do they want to have a funeral or have a Christian burial for the fetus? Which I was never involved in until recently, because I never really thought about that until somebody asked about it. And now, yes, here in Our Lady of Mercy Cemetery provides that facility. So if a woman delivers a baby, or even a very early pregnancy under 12 weeks, and she wants that baby buried in the cemetery, Catholic cemetery, she can do that.
Wow.
Hmm?
That's awesome.
Are you?
Yeah.
Oh, congratulations. Congratulations.
So far.
That's wonderful.
That's awesome.
Okay. Let me go on. What am I up to here? Okay. Now, when it comes to shared decision making, what are we talking about? This is work that was done by a couple, the Emmanuels, who published this in the JAMA in 1992. Yeah, in 1992. They published this work in JAMA, and they were about various methods of shared decision making. Okay, and this is when all this idea of shared decision making was becoming more and more prominent, and trying to discuss how would you categorize shared decision making. And so what they discussed was 4 types of shared decision making, paternal, interpretive, deliberative, and I forgot the fourth one, but it'll be here in a minute. And the whole idea was that every member of the medical care team and the family should be invited to participate in discussions regarding patient care. If you have a patient who's in the hospital, for example, and there are multiple doctors involved in the care, that team needs to come together as a team to discuss the patient with the family, first with the patient, and if the patient wants, with the family, to discuss the patient's problems, the proposed methods of treatment, the outcome, the risks, the benefits, and it's hard to get a team together. It's not easy. So sometimes what happens is one doctor comes in and tells them one thing, another doctor comes in, the third doctor comes in, the fourth one comes in, and nobody's communicating with anybody. And that's a real problem. In today's medical world, it's a real problem. So the primary responsible physician is the one that then has to reach out to the others to make sure that everybody is on the same plane about what's going on. We have to ask the patient, how do you feel about this? What do you want? We present the procedures to you. Which one of these is a procedure that you would be willing to choose? What is your values for this procedure? In other words, you really want to get the patient's input as much as possible as to how they feel about everything and what their preferences are. Now, some people can't do that. They don't know. They have no idea. They don't know how to do it. So that's where you invite family to become involved. In a poorly educated situation, the family still and the patient still may not be able to come to an agreement as to what they really want. And that's where you as a caring physician have to really kind of try to interpret what the patient might want to do and then discuss that with her. And it takes, as I said, a lot of time to try to get to where that's all about. But the big thing is to try to get them to understand, provide them educational materials in their language, okay, at a reading level that they can read, but got to be sure they can read, okay? So everything is about trying to accommodate as much as possible the patient. And the educational tools are your teaching tools. And you can do this through pamphlets, through videos in the office, internet. There's so many different ways you can do it today that make it much easier. But of course, you have to have internet, and not everybody does. Okay, so the challenge is, as we talked about, to get the patient involved is the level of the patient's education, the language of the patient. What kind of emotional support does she have or he have from the family's perspective? Does he have any? Is he all alone? And so many people are all alone. You would not believe so many people are all alone, okay? Or they have family, but the family doesn't want to get involved because they don't want to be responsible for any decision making. And especially if there's money somewhere, it even becomes more of an issue. And they may even abandon the patient altogether. So the poor patient is there lying by themselves and nobody's helping the poor patient. Sometimes you have to bring in counselors who can better work with the patient than you can to get the patient to understand some of the issues that they have and that they're dealing with. This is where the chaplains are often of great benefit because they can really relate to patients differently and get the patient in a better frame of mind to understand what's going on. And then when it comes to patients who are in the hospital, near terminally ill, you really have to get them to try to make their own decisions about how they want the end of their life to be without euthanasia, no euthanasia. But what do they want? Do they want to be on a respirator or not? Do they want to be resuscitated at all? Let's say they have a cardiac arrest. Listen, a terminal end-stage cancer patient, okay? You would think that they would not want a resuscitation. If they have a cardiac arrest, you would think that they would not want to be resuscitated. You'd be surprised. They do, because they don't see that they're dying. They really don't see it. They don't accept it. I'm not saying they all, but there are some who don't accept that they're actually dying. They won't recognize their diagnosis. We just had a lady that we were supposed to take to Lourdes from Los Angeles last week, 2 weeks ago. And she was she had stage 4 cancer of the ovary. She had a train coming out of her abdomen. She had lost massive amounts of weight, but she wanted to go to Lourdes. And so when she was broached about the airplane trip and the possibility of a cardiac arrest on the trip, she wanted to be resuscitated.
On the plane?
On the plane. And they had everything.
They can do that?
Oh, first of all, you put her in the back of the plane.
Okay.
So we make sure that she's in the back, so you don't disturb the whole plane.
Yeah.
And then you got to get her on the floor, and you do the cardiac massage, and you ambu, and you do what you have to do.
And nobody will know what's taking place.
Well, the flight crew knows, but most of the crew, most of the passengers in the front of the plane won't know. The passengers in that section will probably be aware.
Oh, would the airline allow that?
Yeah.
Oh, wow.
Wow.
You only tell them so much. Yeah, but she was determined, and I was like, I think this doesn't make sense. I really was. I said, if she's dying, why don't we just let her die? Why did you even bring up the resuscitation? Well, we have to. I mean, I know we have to, but do we all have to agree to that? Where do you draw the line?
So
Well,
did she
fortunately,
go?
she solved the problem.
Did she go or?
She solved the problem. She died. She died before she got on the plane. She could have died on the trip, no question. But she wanted to go to Lourdes. She didn't care if she died in Lourdes. That was okay. She was very happy to die in Lourdes.
Yeah, of course.
But what they don't understand is it's not a simple thing to die in Lourdes, for example, because now you've got a body, and that body has to be treated according to European standards, and then it has to be transported, and US standards, by the way. So it has to be transported to the United States, not in a coffin, but in a casket, which is something that would have to probably be sent from the US, because in Europe they use only coffins. In the United States they don't use caskets like we do.
What's the difference between a casket?
Casket it's lined, leaded.
Oh, they just do wooden.
No, they just said wouldn't.
But in concepts, in some countries, it's more rigid because a very close friend of mine, we grew up together in Port Antonio. He died in India, and it took his family 3 months to get the body.
Yeah, because they go on a space available basis. Their flight.
No, they will not turn over the body for 3 months.
Mm.
They will not give the family the body in India for 3 months.
Well, I know in Lourdes it's a space available basis. If there's no space on a aircraft, they don't go until there is a space available on the aircraft. And it can take months too. But I mean, these are issues about resuscitation. It's a very personal decision. It really requires actually good counseling and communication and understanding by the patient, the family, and whoever the surrogate for that patient might be that's going to sign things if the patient can no longer sign for themselves. The patient and the surrogate have to really communicate about what the patient wants. Otherwise, the surrogate doesn't know what the patient wants, or the family doesn't know what the patient might want at the end of life. Okay? And our responsibility at the end of life is to make the patient comfortable and pain-free as much as we can. Okay? And that's ideally what we should do, and not giving them, as I'm sure Father has talked about, not doing things to them that are painful, disruptive, uncomfortable, not conducive to a peaceful end of their lives. Okay? Any other questions about that? Okay, so now let's deal with the 4 methods of shared decision-making. We've really kind of covered pretty much the paternalistic one. And here, the assumption of autonomy, because we're talking about patient autonomy, as the patient agrees to the objective of the physician. Okay? So that's where the patient's autonomy. The patient really her autonomy is related to how she accepts or he accepts the doctor's or provider's decisions. Then the interpretive method is these you spend time communicating, finding out what the patient really wants, how they think, what their preferences are. You give them all the kinds of, every kind of information you can give them that's relative to them regarding the risks and benefits of interventions and what they might realize as outcomes. You have to make sure the patient clearly understands what's relevant. You don't bring as a physician, you do not bring anything of your own values into the discussion. That is out of the discussion altogether. It is important to try to understand the patient's feelings about everything. It's important that the treatment best fits what the patient's values are, okay? And so here, the physician is a facilitator or a counselor. Why don't we take a break since she's gone to the bathroom? Let's take a break. Okay, everybody, we're going to break for 5 minutes.
Okay, here's a little dot. We're on.
Now, are they on?
They should be comment. I don't know how to do that part.
Okay.
But you see, I know we're recording now. You see that little circle?
Okay.
That
All right,
little
everybody, we're back together. And we left off discussing the interpretive component of shared decision-making. And we're
Father, are you there?
What about John?
We're from John. He might just sign on quietly.
okay.
Let me just text Father
You
on
want
the
me to
topic to
text
see
John?
what we verify here on.
We'll text him.
Oh, yeah.
2 others are on a retreat.
Yeah.
Adriana and Helen.
What's his name, Father?
Pierre?
Damien?
Hello.
Oh, here, one's on. Okay.
Good.
We're just trying to
Yes.
find out who's on, if you're both on.
Yes, I'm on.
Okay, thank you for letting us know.
Okay.
No, that's Father. Yeah, but at least they're on.
He's in
We
New
don't
York.
turn them on, they turn on.
Okay, all right, so we'll move on. So the next one is the deliberative method of shared decision-making. And here, the physician is more active. He is more giving information on the clinical situation, getting for the patient what the patient's best determined health values really are under the circumstances. Now, what happens, the difference here is that the physician indicates what could be done, but since he knows the patient and is wishing the best for the patient, gives his opinion of what should be done. There's no moral persuasion, coercion is avoided, and the patient defines his own life and values. So here the concept of autonomy is moral self-development. The informative, which was the one I couldn't remember before, decision consumer is a consumer model. So we all know what consumers are like. You get all the information from the physician about what the disease is, the diagnosis and treatment possibilities, and the risk and benefits of those treatment possibilities. And the physician shares any uncertainties regarding the knowledge of the treatment, the diagnosis, or the risks and benefits. The patient's values are well known to the patient, but the patient doesn't really have all the facts. And these are to be provided by the physician. Then there's an assumption that there's a clear distinction between the facts and the values on the patient's side, and the values determine the treatment. There's no role here, again, for physician's values or understanding the patient's values, judgment, or worthiness of the patient's values. The patient's obligation is to be truthful about what his values and views or her values and views are, to maintain competence and consult appropriately with the physician. The idea here is, in the terms of patient autonomy, is that the patient is in control over all the decision making. And that's becoming more and more the case, by the way.
Or it's up to the patient.
The patient's in control, becoming more and more the case. But the manuals who do put together these 4 components prefer the deliberative, because in this case, the doc is caring, he understands the patient, he integrates the information and the patient's values to recommend and encourage decisions. So the doctors are really caring about what happens here and how the patient thinks and how the patient feels. And he wants to give, he or she wants to give the patient the best potential treatment for the diagnosis. So he attempts to persuade the patient regarding the best treatment. The physician's values are relevant to the patient, okay? Especially, for example, if a woman is pregnant, she's choosing a pro-life doc, okay? That means her desires are relevant, okay? And so the physician has to be, what she chooses would be her pro-life physician.
Well, is it standard procedure for the doctor to declare themselves as a pro-life doctor?
Not really, unless they're asked.
Unless they're asked?
Yeah, some people, it's well known in the community that they are, you know, it is well known.
I picked one.
It's, you know, sometimes it's well known. You have no concerns about it at all. You kind of, and you know it by the way they practice. You really get the sense quicker. So the physician wants to fit the patient's therapy to the patient's values. And this could be things like, for example, one of the things that you want to do to prevent disease in patients is and prevent them from getting complications. So you want to, for their values not to have these things, you want to encourage them about smoking, not smoking, avoiding safe sex, avoiding smoke and alcohol. So these are the things that you would, as the physician, knowing what the patient feels about their own life and their own values, say, well, listen, you know, if you stop smoking, you won't get cancer. You're not likely to. If you stop drinking, you won't have problems with your liver in the long term. If you are careful with sex partner, okay, in fact, you have one partner, then you're much less likely to get sexual transmitted infections. So it's really looking at the concerns of the patient and knowing how the patient would want you to deal with them. Now, there are circumstances which will affect the choice. For example, somebody comes into the emergency room, there's nobody around, there's no information, you have to be the paternalistic doc. The patient comes in, they've had an auto accident, there's no information about what they want, they can't talk to you, for example, then you have to make the best decisions that you can make at that time for that patient, not knowing anything, okay? And that's very paternalistic. Interpretive is at the end stages of life, when a patient does not want to live longer, or they don't want to prolong their lives, but they want to have the care that's necessary, not to shorten their life either, but not to prolong life. For example, intubation is one. Another one is giving narcotics towards the end of life to relieve pain. We all know that morphine decreases respiration, okay? But if you're in pain, what's the more important thing? The most important thing is to try to relieve the pain so that you, the patient, can better deal with your end of life issues and with your creator, okay? You can't do that if you can't breathe, I agree. But you can't do it either, and much less so if you're in pain. So your intent is to relieve pain, not to shorten the life, even though you may know that that's what's going to happen. The life may be shortened because of the drug you're giving, it's to relieve the pain. So your intent is to relieve pain. The second side effect is you may shorten life, but you're not doing euthanasia, okay? Unfortunately, in some of our hospice situations, it doesn't go that way. They are more towards getting to the end of the life than they are. I just had a friend who, I don't know why she was in hospital in the first place, but anyway, she was getting narcotics all the time.
But isn't hospice like right because you're gonna die? Like they put you there?
Usually it's end of life, but end of life is a lot of different things. Okay, the patient is expected to die within 6 months. Then they can be put into hospice. Now, some of them don't die in 6 months. Okay, they live longer, but they're not getting the same kinds of drugs. They're in hospice for palliative care, but they're not getting the same kind of drugs. Then there are those who are in hospice because they truly are at the end of their life. And so they're getting treatment for just that. But hospice is a money-making business. Don't ever forget that. Okay?
I thought it was a Catholic thing.
What?
Started off.
There is Catholic hospice. Okay, there's hospice, there's non-religious, and there's Catholic hospice. And really, you're better with, at least for us, we're better with Catholic hospice. Okay. Now, my sister was in hospice, and I controlled everything. And my other sister, you know, the question was, who's going to take care of the drugs? And I said to her, I am.
You did?
Oh, of course. Because I knew my other sister would give it to her. And she would, you know, she'd say she's having, because she kept saying to me, she's having pain. I said, Ann says she's not having pain, Kathleen. And I have to go with what Ann says. Well, she's having pain, but she's not telling you. I say, okay. But she tells me she's not, and so she's not getting it. In fact, I had her off morphine altogether. She was on it for 36 hours. And then, you know, I said, I was reducing the dose just to see. And then I said to her, you know, should I give you your next dose? She said, no. She went like this. And, you know, I waited hours. Are you okay? Do you want any morphine? Mm-mm. She didn't have it and then for another 5 days until she died. So I know it wasn't the morphine, which is nice, believe me. Okay. And if it's, you know, if you have only one decision, one time you have with the patient, then most of your shared decision making is giving a patient information. Okay, now when it comes to these shared decision making models, you can frame the discussion to achieve what the physician wants. The physician can really do that, but that's not what it's about. It's not really about that. So you shouldn't be doing just that. Okay, now comes HIPAA. HIPAA came about during the AIDS epidemic with the idea in mind that partners of AIDS patients who were dying, who were not relatives, could not get information about their partner, male or female partners. The hospital could not tell them anything. And so by the laws that were present at that time, before that time. So HIPAA came about to change some of that. And what HIPAA really ended up becoming was the doctor and the patient's nightmare about release of information. I mean, it is an absolute nightmare. Because in order for the patient to release any information, for example, you have to have a signed, conformed consent. You have to be very careful how you share records. Right now, there's a big to-do going on about records appearing on internet, which is inappropriate. Even no matter how you look at internet, you cannot be certain that sharing of any kind of a medical record on the internet is not going to be hacked. So my personal opinion is no medical records should be shared on internet. We have a little bit of a problem with that recently with our trip to Lourdes, and which I voiced many objections because they had some special internet provider that they did this, and I said, you better not do this because this is legal about documentation. And they don't understand that even though the patient has released the information to North American Lourdes volunteers, doesn't mean that it can't be hacked and got at in another way.
So what is that? You have to send it before you could get there? Lourdes?
No, they have to, they always send in whatever we want, directly mail it in to Lourdes. Okay, then what's happening is the nurses and the physicians were sharing the information amongst themselves on internet. So instead of having the paper copies to take with us to France, the idea was to have copies on internet that we could go into and not have to carry all this paper.
Right, like on email.
Yeah, but it was a special provider. Anyway, I would not use it. I said, absolutely not. I want records. Bring, forget the paper, okay? But HIPAA is, the lawyers have taken HIPAA to the extreme end of paperwork off the wall. And we can't do anything about it. Okay. So now what can a healthcare, with HIPAA in mind, what can you tell a patient or a family as a physician? Well, they have to be involved in the patient's care in some way or another before you can tell them anything, or the payment of the patient's care, before you can release any information. And the patient has to specifically agree that that information be revealed. Even in the case of the teenagers who come for GYN care, you don't have to tell the mother anything. In fact, you don't examine them with the mother at all. You get the mother out of the room and you talk to the teen. So if she has an STD, you can treat her. Okay, if she's pregnant, you tell her. If she wants to have an abortion, you're supposed to refer her. You don't have to tell mother nothing. Absolutely nothing. Who pays the bill? The parents.
That's crazy.
Yeah, but you don't have to tell the mother anything.
What's
Nice.
the logic behind that?
Because it's confidential information to the teenager. And it relates to her sex life, and you don't discuss her sex life with her mother.
You know what's insane about that? That, like, being a teacher, you have to get a consent. I have to get things signed by the parent. You know what I mean? For stupid things, when this is something serious involving health. I'm supposed to pay for that?
Yep.
When
If she
did
wants
that change?
contraception, you don't have to tell her mother, you just give it to her.
But that to me, that sounds like more convenience than anything else.
It's convenience for the teenager.
But the teenager is still, I'll say, underage,
Right, a minor.
young minor.
Yep.
And so that's what I mean by convenience. So when it suits us, we make it convenient
Right.
for and so there's really no fixed law. I mean, that's crazy.
Because then for school things, they should be able to do whatever.
Well, this is only related to medicine. I can only talk about
Yeah,
medicine.
yeah.
Okay? This is only related to medicine. And for example, if that same teenager comes in with a medical problem that has nothing to do with this, no, then you have to discuss it with the parents. But when it comes to this aspect
Wow.
of her sex life,
Incredible.
no, that's confidential information. So you cannot discuss it unless the teenager says it's okay.
I hope the teenagers don't know that.
Yeah.
Well, they know. Are you kidding? Of course they know, Deacon.
Wow.
They know full well.
So they don't have a responsibility to, that's what it comes down to. They don't have a responsibility to their parents.
For
when it
this,
comes to
no.
their sexual behavior.
No.
Wow.
From a medical perspective,
I'm homeschooled.
from a legal perspective, you're right. They don't. It's a legal
You
perspective.
see, I teach also, so I'm looking, and I teach teenagers, so girls. So I'm looking at it from that perspective. I understand now, you know.
Mhm.
This,
Now you know what I dealt with, because he's working at the school I used to
Yeah.
work at, all girls.
I don't even know if
And I
I
used to
survive.
teach biology, so I have to
Yeah.
discuss it. But I
I
feel like
teach
some of them-
religion, so, you know, moral, so.
Well, these, our society has so changed that it's really the parents' responsibility to sexually educate their children. And if they're not going to do that, and they don't do it from a very early age, this is part of the consequence.
But part of it is that a lot of the parents, they never used to behave the way their kids are behaving
No.
today.
But they listen,
And
Deacon, parents read today. They know what goes on. They know. They have to. They can't be blindsided.
we
It's
assume
somebody
that-
else's child, but they don't think it's theirs, and that's the problem.
Yeah,
so
They have
don't
to think
know.
it's theirs and start from the beginning.
started at home.
Exactly. It should all be started at home. They shouldn't be learning this thing in school and these things in school.
Yeah.
They've already had the experience. I can tell you, they've already had experience. Many of them. By the time they're 12 years old, they've already had some experience of one sort or another. And then the older they get, the more they have.
So depressing.
So the patient has to give oral or written consent for you to relate information to family. And the same thing with a teenager. If you don't have her consent to talk to her mother, you can't. From the things the things I just talked about.
Who do you think you are? I'm going in the room.
Well, the whole idea about this is that if they have to go to their mother may not let them have birth control, and they're still going to be out there and be sexually active, and they're still going to get STDs, and they're still not going to have medical care. So at least if they know that there's a place they can go and they can get what they need for the lifestyle that they're living, then that's protects them.
But
I'll be like, go live somewhere else if you're not living under my roof.
but in a sense, it's not frame of mind coming from the idea of the practice they do in San Francisco. Well, we know everybody's using
Drugs.
syringes, right? So why don't we just sort of cut that down and just give them free syringes?
Mm-hmm.
You know, I mean, where's the education aspect of all of this? It's not making any sense.
It's hard to understand that
Yeah.
on one hand. On the other hand, it's easy to understand. I mean, wouldn't it be better if they're going to use syringes to have clean, sterile syringes and not sharing, where sharing spreads every kind of infection going? I mean, if they're sharing needles, then they're going to share the possibility of hepatitis B, hepatitis C, HIV.
I understand.
Okay, but clean, sterile needles decreases that possibility. If they're in a unit where, and I'm not saying this is right, but if they're in a unit where they're being observed while they're getting their drugs, okay, then if they have an overdose, they could be treated right away.
Just for being so lenient. So,
Yes.
like whatever the people want, whatever the kids want, like where is the authority? And that's really
Well, you have to be careful about authority too, because you don't want the government telling you, the government is telling you now. You have to worry about this, how much control does government have over what we do, okay? And if the government decides this is how you're going to live your life, okay, then that's what happens. If the government says we're going to withdraw all of this and not pay for it, okay, do we really know that that's going to decrease the amount of drugs being used? No. What has to happen is we got to stop the drugs getting in. And that's what we're not doing. We're not stopping drugs getting in. Why? Because there's big bucks out there. There's lots of corruption out there in this whole drug field. And believe me, everybody's involved. Everybody.
But even with like the pharmaceutical companies and birth control, they're making it a money-making machine too. So
Yeah.
Just give the kids the pills, but what about educating them on all of the side effects?
Nobody educates them. And I was giving a lecture at Palmetto a couple of, maybe 5 months ago, 6 months ago. And one of the things that we were talking about was contraception. And I made the statement that it is potentially an abortive patient. And oh my God, I got all these objections. I said, anybody ever read the insert? None of them had ever read the insert. I said, then don't tell me I'm wrong. Go read the insert. It says it right there.
As a doctor. That's crazy.
Well, they were doctors.
Oh,
They were doctors. Yes.
I didn't even know this. This is insane.
I said, read the insert.
It's
Go find
funny
out.
because my husband got in a fight with somebody on Facebook about that too. And I'm like, are they really challenging you? You're a doctor. Like, who the heck are they? Who challenge you?
Well, everybody has a right to challenge you.
I know.
But you have to defend it in the appropriate way.
Right. No,
Yeah.
It's always.
Okay.
No. Crazy.
Okay, the patient has, the other things the patient can share or tell family is when the patient does not object to the provider discussing things with his family. Talk about his status, but not always about his diagnosis. That's up to the patient to decide. Or if it's in the professional judgment of the physician that the patient would not object, then he can share information with the family. And in medicine today, overall, when patients come for care, about a third to half of them never comply. They may fill a prescription and take a drug for a while. Or they may fill the prescription and not take the drug, or or they may not take the drug in the first place, but don't tell the doctor that. I mean, it's okay if you're not going to take the drug, but at least tell them. Okay? I have no problem with the patient telling me, I'm not going to take that medicine. Fine. I mean, I do the same thing. I would tell my own physician when they wanted to put me on statins, I said, I'm not taking them. I'll find out some other way to bring this down. I'm not taking statins. First of all, we don't even know if they work at my age. Okay? She said, you're right.
My doctor says,
So-
I know you don't like to take pills. However,
Me too.
But that's the point. You need to be upfront. There's no point in wasting time. Okay? And if you're upfront and you say, I'm not going to take them, and you've gone through everything to educate the patient about why they should, and you document, and now it goes like, you have to document. But you document on the chart, then the physician's not liable. Okay? And it's really a waste of everybody's time if you're going to go to a physician and get this information and then do nothing.
That's what my question
It's a waste of time. So what's the point of being here? You know, no, there are reasons, of course. Can't afford the medicine. Okay, and in today's world, with even all of our insurance programs, people cannot afford, the older people, many of them cannot afford their medicine. So what do? They'll take one day, one another day. They'll pick and choose. So they're really not getting the care that they need, okay? Diabetics do that notoriously. Some days they take their insulin, sometimes they don't take their insulin because they know they don't have enough to get them through. They stretch it, they do whatever they can. Or, you know, if you assume that the patient is going to do what you say you're going to do, then your communication with the patient is lacking. Okay, and that's how you have to really get to it. Sometimes they won't take their medicine because of their own mental status. Okay, sometimes they won't take it because this so-called shared decision-making was paternalistic and not with any input from the patient. Sometimes they need home health care to help them adjust to what they need to do, and you haven't provided that for them. Okay, and of course, as I mentioned, in a short doctor's visit with electronic health records, it's very, very hard to communicate adequately with the patient. So everything is done by paper. I noticed that. I was going through some things for a patient the other day, one of our people at church, and she didn't have much information about what she had, but she had the laboratory information, she had the x-ray, and then she had this reef of all kinds of information about things that were somewhat related, but had nothing to do with what she had. Nothing. So, you know, they try to provide it in other ways, but you have to make sure that the information that you're getting, so-called educational information, is relevant to the patient. And if it's not relevant to that patient, then it's a waste of money. Then there are patients who are difficult. They don't want to do anything you want them to do, or anything that you think that they should do, okay? Or the insurance plan dictates the kind of care that the patient gets. For example, there are some insurance plans that won't allow you to do B unless you do A first. And you already know, and you have all the information to know, that they don't need A to do B. But they have to have A before B can be done. So what does that do? Drives up the cost of care. And of course, we as physicians, you know, every patient's a lawsuit. Every patient who walks through your door is a lawsuit. And for those of us in surgical specialties, we're well aware of that. Other thing is you have to document everything you say, everything you do, everything the patient says. Document. And I would always show the patient, many times I would show, this is what I'm writing. I want you to know this. This is what I'm writing down on your chart because this is what it said. You told me you don't want to do. So just make sure I've got the right thing down here. And they agree. Let's see. The patient's not getting what they want. You're not offering what they want. Okay. And even if they try to tell you what they want and you're not participating, then they're going to refuse to do the kind of care. And that's okay. If they can refuse the care that you think is best for them, that's fine. I talked about Jehovah's Witnesses, so I'm not going to go there. Okay, the other problem you have as a physician is disruptive patients in the office. Patients who create chaos in the office, and try to always get those patients scheduled for the end of a day, not in the middle of office hours, so they don't disrupt the whole office. And it really requires a lot of patience on everybody's part. And sometimes the staff has no patience for it at all. The nurse, the front office staff, and they can be not so nice. So you have to intervene because you don't always know, you know, you're the physician in the back. You don't always know what's going on in the front at all. And your front office is your, how do I say, is what makes you or breaks you, is your front office. So you schedule disruptive patients at times when there are not other ones around. Okay, what are some of the mandatory things we have to deal with? We have mandatory requirements for abuse, which you need to know the state laws and exactly what those laws are for each state that you practice in. And you always should tell the patient before you notify the authorities.
What do you mean by confidential information for the teens? What is, I mean, the sex part, I understand.
We discussed it. That's
That's
confidential.
all.
Yeah. Right. Or the teen tells you something that they don't want you to tell their parents.
Or so they can say, okay, don't tell mom this.
Well, right. I'm going to talk to you about this, but don't tell my mom. I mean, you got, for example, if a teen is in an abuse relationship, okay, you have to get that teen to know that you have to report that.
Yeah.
Okay, by law, you have to report that. And ideally, you know, she should get out of it. But by law, you are supposed to report that.
What about suicidal?
Oh, that you have to. Yeah, that's altogether different. That's a whole different ballgame. Okay, but you have to be very, very careful with the teens on what you do and don't do. And then, like, for example, getting court orders for procedures. Let's say a cesarean section in a patient who's absolutely refusing puts you, the physician, in an adversarial role. You know, because you're forcing the patient to have a procedure that the patient doesn't want, even though it might be in the best interest of the baby. Sometimes you do it because you know that the patient is being pressured and it's not what the patient wants. Okay, for example, family is pressuring the patient not to have a cesarean section when in fact she needs that cesarean section because the baby is not negotiating the pelvis. So you might have to go court to get that cesarean section. And the patient is very relieved because now she's getting what she knows she should do and she's not being pressured by family or husband or whatever, okay? So, but you really don't want to get yourself in that kind of a role because it makes it very difficult, unless it's a minor, then you have to. Okay, now when it comes to this whole story of autonomy in today's world, with internet and so much information available on internet, and the marked advances in technology that have occurred in medicine today, both in diagnosis or prescribing or treatment, so much more information is available to a client, to a patient, to a client now we call them, but to a patient. And they can come in with telling you exactly what they want. They can even order medication and laboratory work on internet, and you don't know. But they can do it on internet, send in the blood to get genetic studies, for example. They can do that. They can order medications on the internet. You can get abortifacients on the internet. And right now the federal government is looking into that, but you can get abortifacients on the internet and do your own home abortion, chemical abortion, without knowing anything other than that you're pregnant. And believe me when I tell you, people come in for ultrasounds, they're not always pregnant, first of all, but secondly of all, they're not always at the gestational age that they think they're at. They don't always have a heartbeat. So they're doing things that may not be indicated without having the adequate or proper knowledge in the first place to do what they're doing, okay? And educational materials on internet are not written always by the right people with the right information, and they're not always authoritative. But the patient thinks it's on internet, it's reliable, okay? So this confuses the picture in today's world for some. Not all patients do this, but there are some that can be extremely difficult and make it very, very hard to deal with, to come to terms with, to rationalize with, and to make the decision that you will or will not comply. And it's all in the role of autonomy. You have to listen to what they have to say. You have to try and rationalize with them and get them to understand, why did I go here? Get them to try to understand the fallacy of where they're coming. But believe me, I've been there, and sometimes you can't, it's like talking to a stone wall. But it's there, it says, don't you see, it says that right here. That's not right. Well, why does it say it if it's not right? Of course it's right. I got it on internet. No. Okay, so now the next few slides are in, well, we have time. The next few slides are all dealing with the patient-physician relationships from the USCCB 6th edition of the directives for Catholic facilities. And what I have done here is I have just shortened them just so that we can go over them and at this point, and if we have any questions, answer them.
I think we all saw the booklet, right?
Yeah, you do.
Yes.
You're right. So they're all in there.
Yeah.
And I guess what I really should do, I put them in here, which because I shortened them.
Yeah.
And you'll have them on your slides, because I think he's going to give you a copy of these slides. I hope.
Yeah.
But if there's any questions about any of these that you would like me to discuss, please ask me now. Anybody has any questions out from outside or inside? I guess not, huh?
Well, okay, let's, the third bullet point here.
Mhm.
In many families, for instance, you might have only one or two members of the family that are say Catholic, right? How do you deal with those who are not? In explaining, especially when it comes to inner life issues.
Well,
how do you deal with those who are non-Catholics?
doesn't matter whether they're Catholic or not, you're going to deal with them the same way. Okay? You have to deal with them the same way. I mean, you expect the Catholic to know more than the non-Catholic? Don't think that way, because they don't. Many Catholics have no idea. I mean, they're Catholics.
It's true.
Whatever that means.
Oh, yeah,
Cafeteria.
it's true.
Okay?
That's true.
So you
Yeah.
can't do that. You have to deal with them regardless of what their religious background is. In this, we're talking now about a Catholic facility, okay? That's what these are, related to Catholic facilities. But at the same time, as a Catholic physician dealing in sectarian facilities, you really would like to practice as much as possible in the same way, okay? So that's what you try to do. Try to do it as much as possible in the same way. A Catholic facility just makes it easier because the patient already knows they're in a Catholic facility.
Yeah.
Okay. So in some ways it does make it easier, even though it can be very difficult, and it can be very difficult.
Yes.
And I think the big thing for all of us it shouldn't just be medicine. For everybody in today's world, everybody should have some kind of a plan of how they want, what they might want if they're critically ill. Okay, because you can be critically ill at any time. It doesn't have to be that you're 60 years old or 80 years old. You could be critically ill at 25. Okay, and of course, who at 25 is ever going to think about intubation and prolonging life? And even when you're really prolonging death, you're not prolonging life. I mean, when the system is shut down, you're prolonging death by keeping a respirator going.
Like that lady, Shiva.
Yeah. Mm-hmm. Yeah. Terry Shiver.
Yeah,
Mhm.
Terry.
What about her though?
No, like I don't think she had a will, did she? She was young, and then she had.
Well,
like,
according to her husband, she stated what she wanted. According to her parents, she did not. No, but she couldn't tell us. So it's, and there was, if you go I'm sure Father has discussed this
Yeah,
case,
yeah.
the whole story. He had a reason to get rid of her.
Yeah.
He had a
her
reason. Yeah.
Wife,
$1
her
million.
lady, and then a kid.
But he will pay his price. I mean, he has to deal with God in his way. That's all you can do. That's all you can say about that.
I wonder what really happened to him.
Well, he got married before she passed away, I think. Or she got married after. But
You
he
know,
had his girlfriend
after,
before.
but he had a child with that
Yeah.
woman.
So like she fell in her house.
Well, what really happened to her in the first place?
Yeah. Yeah, exactly.
We don't know.
We don't know.
Well, how did this all come about in the first place? We don't know.
That one was never really clearly answered.
So I think one of the things that's very, very hard to do is when you have a critically ill patient is to get the family to come to terms with how ill somebody really is and what they could or could not expect. Even we don't know many times what's going to happen. You know, we can only predict relatively, but in the long run, we don't know because it's God's in control. We're not. And we don't always know what's going to happen. We don't always whether they're going to survive or not. And how. I mean, somebody's had such terrible injuries. We don't know what the long-term outcome is really going to be till you see it. And then, you know, people surprise you. I mean, they can be in coma for weeks and weeks and weeks and come out of coma and be fine, or come out of coma and be incapacitated in many ways. And yet, with rehab and so on, can really recover a great deal of what they are, of what their capabilities are, and function perfectly fine. Not be as functional as they would have been otherwise, but can really have a good life. So we have no way of predicting, no matter how much we think we know. To a limit. I mean, there are some things, yes, we can, of course. But a lot of things, no, we can't. And things change in medical care, too. Advances change everything. So that's the first group. Then the second group of the directives, I think what's interesting here is, oh my goodness. I didn't obviously correct this. Preserve and protect bodily and functional integrity. This is very important, that we really treat critically ill or end of life or elderly in a extremely charitable, loving, kind fashion. And that's hard to get people in a hospital environment who are used to dealing with things that they don't always have patience, they're not always kind, they're not always gentle, they're not always loving. And patients can feel it and are very much aware of it. I can remember my own mother being in the hospital. When she was in, and we would never leave either of my parents alone in the hospital. Since I was a nurse and I was a doctor, my sister was a nurse, we knew what can happen. And she got this one nurse, and I could see just the way she was following her eyes, watching this nurse. And then the nurse would go out of the room and say, watch her. She said, watch her, watch her. My mother had Alzheimer's. And that would be the only thing, maybe the only few words she could say. She did not, there was something about that nurse that was not to her liking. No. Okay, and so why, you know, you gotta, and if the patient tells you something like that, you need to listen to it, because maybe nobody else is telling you that the care or the care is not what it should be. I suppose fathers discuss transportation, right? Transportation of organs?
Yeah.
Okay, I'm sure he has.
No, he will talk about it at the end.
Well, anyway, you can, it's accepted now, and has been, I guess, for a while, that you can transplant organs so long as it will not totally and significantly impair the donor, the function of the body of the donor, and it will benefit the person to whom the donation is going, but the cost to the donor is none. Okay, and will not have any significant impact on the donor itself. Okay?
But I think the key word that you used there is significant.
Yeah, significant impact. I mean, a kidney, if somebody has 2 kidneys, but one, and they want to donate, but they have some type of kidney damage, okay, that's not a viable donation.
Oh.
Okay, I think that's the best way to put it. Okay, it has to be person who's donating an organ of which they can do with one, but they're giving one. That organ, both organs have to be normal so that they can live without one perfectly fine. Okay, but if one is damaged, then they can't transplant the damaged organ. And if they transplant the good organ, then they're significantly risking the damage themselves to damage. Okay. I'm just looking at this so I can see if there's anything that, oh yeah, I think this last one on this slide, compassion for sexual assault victims, that's something that women will tell you all the time. If they've been a victim of a sexual assault, first of all, that's the trauma of that event, which I don't think men can understand. I really don't. Maybe men who've been raped will understand, but I don't think men generally understand. And I think a lot of women don't get it either. And I say that from somewhat from experience, somewhat from watching even the media and the reactions regarding sexual assault victims. It is a very profound psychological devastation to be sexually assaulted. And therefore, when such a victim is seen to have the evaluations that they have to evaluate from a legal, they have to have from the legal perspective, if one is going to pursue this assault, the examination itself has to be handled with such gentleness, because it's degrading. It's an invasion. Now you're being invaded again. You were traumatically invaded by your assaulter, and now you're being invaded again by the people who are trying to help you. But that doesn't take away the trauma of that invasion. I don't know if, do you understand what I'm trying to say?
Yes.
Yeah.
Okay. So it really involves a great deal of passion, compassion, kindness, gentleness, understanding, listening, in no way expressing or any form of judgment, because, and it's hard to do too, depending upon who you are. I mean, you may not even think you're expressing anything, but the patient or the victim will see something. Okay. And then, of course, any woman who has been the victim of sexual assault has the right to protect herself from potential conception. If she's already pregnant, of course, no, nothing can be done. But if she's not pregnant and could get pregnant as a result of that assault, then she's entitled to take medication to prevent the pregnancy. Okay. It may not always work either. Okay. I see the frown on Deacon's face. What's the frown?
Can you explain that for me?
Okay, she comes in and she's assaulted, and she's worried that she could get pregnant as a result of that assault, but she's not pregnant now. She has a negative pregnancy test. Okay, she can be given and she can take a medication to prevent conception.
Plan B.
Hmm?
Like plan
Yeah,
B.
right. She's entitled to do that and should be offered that.
Okay.
Okay, because she has that right to protect herself against conception. Okay, once conceived, no, that's too late. So once a
So
positive
if
pregnancy,
she's pregnant, she cannot have.
no, and if she's pregnant, it wasn't a result of that assault.
Oh,
If she comes in,
sure.
assaulted and comes in, and then she's found to be pregnant, it was not from that assault.
Yeah.
Maybe it's the same person.
Yeah.
Okay, but not from that assault.
Yeah, because it takes a couple of days for that to happen.
Exactly. Okay. And of course, you have to make sure that you pursue all of the things that need to be pursued to treat her for potential sexually transmitted infections as well. Okay. All right. And these were the references that I used. Okay. Anybody have any questions out there? Because it's a very short discussion this morning.
No. We're fine. We're fine. We're fine, sure.
Okay.
I don't think it's the length. It's not the length that, it's not the length of the discussion.
I just hope it
Quality.
I hope so. Thank you, Deacon. I hope so.
Thank you very much, Doc.
I hope so. The other thing, there was another thing I wanted to mention. I talked about healthcare insurance. I guess there were a couple of things that I wanted, yeah, but I think I did. I think I covered them that are not on the slide. Part of my reading for this. I think I covered them all. Okay. Okay, Deacon, I think you can
you know.
close everything up. Thank you all for your attention. And if anybody has any questions, oh gosh, if anybody has any questions, please feel free to get them to Father, and I'll be happy to answer them if you want to. Oh, God.